Good afternoon, everybody, and welcome. This is the ESRD Learning and Action Network Series, BSI, Quality Improvement Activity. This is Stephanie Hall with the ESRD Ncc. I'll be your host today. I just want to thank everybody for taking time out of their busy day to join us today for this BSI presentation. Just a couple of reminders before we get started. This meeting is being recorded, and so therefore all the lines are muted on our end. If you do want to submit any questions or comments, please do so via the chat section that's located in the bottom left-hand corner of your screen. Also, as a reminder, this audio for this event is available via internet streaming where no telephone lines are required. However, you must have speakers or headphones on your computer to be able to listen to the audio. Troubleshooting echo. Echo is usually caused by multiple connections to a single event. Please close all but one of your browser tabs. CEUs will be available at the end of this presentation. Please stay on, keep your computer on. A post-evaluation will display, and once you complete that and submit that, then the CEU forms will be available. As always, after 10 business days, this recording will be available. They'll be sent out to your networks, and the networks will be sending it out to all the facilities. Part of the presentation today and reasons that we're here for our land is, according to Dr. John Jerrigan, he is with the CDC. He says infections are the second leading cause of death among hemodialysis patients, and many of these infections are preventable. Also, today you'll be able to identify symptoms of sepsis, so action can be taken to improve the outcomes. The presenter today will begin shortly. Has been proven to reduce her BSIs and sustain her BSI rates. She's going to be sharing a lot of promising practices and processes that has worked in her facility. So as you're listening today to the LAN, you want to listen and share your approaches or any experiences via the chat. We ask that you identify how this shared information or these promising practices could be used at your facility. And we're asking that you apply at least one idea from today's LAN that can be used at your facility. Something that can be implemented within the next 2, 3, 4 weeks. Something that was really powerful that can help reduce your BSIs and help prevent the patients from being hospitalized. So what can we commit to do today? After listening to the presentation, and as you're listening to the speaker, just thinking about what we can commit to do, what one thing can you identify and implement from this meeting that can directly decrease the number of bloodstream infections in your facility? So I will now introduce the speaker for today. It's Rochelle Whitmore, BSN RN CRRN, has served as the Renal Dialysis Program Director at McLaren, Northern Michigan for the past 5 years. She has worked with the dialysis nurses, nephrologists, and the McLaren and North Michigan Sepsis Special Project Coordinator on innovative approaches to identifying and preventing sepsis in patients on dialysis. Additionally, Ms. Whitmore holds a Master of Science degree in Nursing Leadership from Walden University. I will now turn over the presentation to Rochelle.
Hello everyone. I'm hoping my voice will hold out for this session. Thank you for the opportunity to present an update on our performance improvement project that we started in May of 2017. As mentioned, I've worked for McLaren Northern Michigan in Petoskey for 14 years. 6 of which have been at the Everett Kircher Dialysis Center. We have a hospital-based program. We have 15 licensed chairs in 1 training room, and we are open from 6 a.m. to 10:30, operating 3 shifts, 6 days a week. We're lucky enough to look at Lake Michigan from our big windows in the dialysis center. Next slide. So the three main objectives for today's session and content include to describe an innovative practice that could help lower your bloodstream infection rates, to help the listener or the learners identify low, moderate, and high risk signs and symptoms of sepsis and the recommended actions to take at each level, and finally to describe potential benefits of using the what we call the ODUS tool, which stands for Outpatient Dialysis Early Warning Screen. Next slide. So I want to provide some background on our performance improvement project that we launched in May 2017. We had presented this project at the webinar last January. So it is exciting to be invited back to share actual data that we have compiled since then. I think it will demonstrate the fruits of our work. So as a background, in 2016, our bloodstream infection rates were unfavorable to say the least. When we looked at a root cause analysis on every single case, we identified that a number of bloodstream infections resulted from other conditions that really had nothing to do with the dialysis access. So we actually performed quite well when we focused only on ARBs, which we all know stands for access-related bloodstream infections. When we actually reviewed each BSI case, we had a number of patients acquiring bloodstream infections from conditions such as pneumonia. We had a few with urosepsis, wound infections, foot infections, spinal abscesses. We had one patient with a dog bite, etc. Next slide. So for us, this was pretty perplexing because we were following the CDC recommendations. We would discuss our infection rates monthly in our QAPI meeting with the nephrologists. We kept coming back to the same thing. Our providers manage the patient's dialysis and comprehensive nephrology needs. However, there really was a real need for better collaboration with primary care providers to address the complicated, complex, and holistic healthcare needs of our dialysis patients. Ironically, on that first slide, I was going to share that quote from Dr. John Jernigan from the CDC about infections being the second leading cause of death amongst hemodialysis patients. I kept that statement pretty close as a reminder of how important this project was to us and to our patients. We were following, like I said, the recommendations and still experiencing substandard outcomes in 2016. We pulled a few of our dialysis nurses to brainstorm and to really try to think outside the box on what we could do to improve our outcomes. I do want to go back to the first step, though, listed in this slide, to follow the recommendations. I put on the next few slides some links with the websites where you can find a lot of these great tools, because if you're not currently practicing all of these recommendations, you need to be, and that's probably the first step. Many of us in the SRD community know that we know these recommendations well, so I'm not going to go through each of them. I'm only going to mention some of them, which includes this poster that you're seeing on the screen, the 9 core interventions. We post this in our department. We review it and re-review it in staff meetings. This includes activities like surveillance, audits, staff and patient education, catheter reduction strategies. We posted the days since last infection. Last year we were posting that in our break room. We pulled out that laminated sign, and now we post it right by the scale where patients see it every single day they come to weigh themselves. So next slide. This link will take you to some of these tools, such as the catheter exit site care tools. It has the audit right there and the checklist, as well as the AV fistula and graft cannulation and decannulation tools. Next slide. We've used the station disinfection audits as well as the checklists. We include all of these things when we onboard new employees as part of our new colleague orientation. Next slide. So despite all of that, we still had a problem, and our rates were not where we would have expected them to be. So innovation is really just coming up with something different. In 2016, it wasn't a good year for us with bloodstream infections, and early in 2017, we noticed we were trending in that same direction. So we decided to focus on sepsis because many of our patients with bloodstream infections also had sepsis conditions. We had asked the hospital coordinator, sepsis coordinator and special projects coordinator, Karen Rahumuliza, to meet with us in our outpatient unit She gave us a number of evidence-based articles that described different sepsis assessment screens, such as, I'm not sure if we can go to the next slide, but the MEOW tool, which stands for Modified Early Warning Score Criteria and Response.
Rochelle, but we're going to take a moment to do a polling question here.
Okay.
And it's presented there. It asks, does your facility utilize the CDC infection prevention audit tools? And we are getting quite a few respondents right now coming in, so we're going to give them just a couple more minutes. We're getting close to 900, over 900 participants answering this question. So let's just see what we get here. I'll just give them another closing. We'll close them now. Okay, so here are the results. So does your facility utilize the CDC infection prevention audit tools that you were just discussing? Out of the, out of the 1,076 answers we got, 41% said they use all of them. 50.5% said they use some of the tools, and only 5.4% say they use none of the audit tools. So it sounds like most everybody is using at least some, if not all of the tools during from the CDC. So that's really good to hear. And with that, I will turn it back over to you.
Okay, thank you. So innovation, we definitely looked at some of the evidence-based tools such as the MEOW, the SOFA, QSOFA, and CRRS. And what we found was that most tools didn't address the outpatient setting, where early identification of symptoms is critical because of the vulnerability of our patient population. Next slide. So when we looked at possibly implementing or applying some of these tools that were already out there, the problem was that patients with end-stage renal disease on dialysis already have organ dysfunction. And they also have vital signs sometimes that are well outside the normal parameters of some of these tools. So to apply any or some of these tools as they were, many of our patients would actually flag for sepsis when they were actually at their baseline. So all we did was really tweak the ranges of some of the clinical parameters to be more applicable to the ranges that we would normally see in the dialysis patient. I do need to put this disclaimer out there. You'll see on the next slide the actual tool. It is not a research tool. We really just created it ourselves based on researching some of these other tools available. And what we really just wanted to do was retrofit something that would be applicable to our unique population. And what's exciting is to finally have some data trends that demonstrate improvements in our outcomes. So here's the tool. It is unfortunately paper. It is double-sided, so you have a 2-week trend that you can see on any specific patient. I want to point out that the top part is the subjective or patient-stated symptoms and is part of the tool, but that part is not scored. You just need to take those subjective statements from your patients when you're critically thinking about whether or not they're developing an infection. The middle section or the middle box is your objective clinical measures, and this is the part that you score. Next slide. So we blew up for purposes of just highlighting how to complete this tool. This section is the subjective symptoms, and I'll just kind of use a fictitious patient to show you how we would complete this. So this particular patient had complained of a cough and felt chilled on one day since the last time he dialyzed and said he was exhausted. So we would just put those check marks there, but again, it's not scored. Next slide. This particular patient has a temp that was greater than 38. So at 38.1, you can see the blue dot that demonstrates that he would have scored a 1 for his temperature. I put his heart rate was at 98, so the blue dot shows that he was less than or equal to 100, so he had a score of 0. His respiratory rate was at 16, so he scored a 0 because he was less than or equal to 20. His systolic rate was at 190, so again, he scored a 0 because he was less than or equal to 199 systolically. During my nurse assessments, I found this patient to be just slightly off, a little confused, definitely not at his baseline, and this particular person also had a catheter. So he had a total score of 1 for temperature, 1 for the change in the level of cognition, and 1 for the catheter, and scored a 3, which puts him in the red zone on our tool. So one of the things I've noticed with this project is our nurses have been empowered by this project to be much more assertive. In the red zone, we definitely have changed the content of our conversation chairside. So if someone's in the red zone, we're saying, listen, I'm concerned. You're scoring in the red zone on my sepsis screen. I really want you to be evaluated today. Do you mind if I call your primary care doctor to see if they can squeeze you in for a same-day appointment? And then when we call, we're asking to get past the schedulers. I'm asking to speak directly with so-and-so's doctor or the nurse that assists the particular doctor assigned to this patient. If they can't schedule a same-day appointment and they're in the red, I definitely would be recommending that they consider going right to the walk-in clinic or to the emergency department. I just want to mention, you can see in the yellow zone on this slide that when they score 2 to 3, I know that's a range, and what we've found is you really have to look at some of your other critical assessment pieces and think about what you know about that particular patient. So if the change of condition is subtle, our nurses have just been using this long enough where they've been maybe going back and looking at white blood cell trends. They might also look at the prior assessment from the other nurse that just saw the patient a couple of days ago. On occasion, I know they've contacted the nephrologist to say, hey, I'm worried about this patient. They're scoring in the yellow zone. They're really not off from their baseline, but do you want me to pull a CBC? And sometimes when they look, the last CBC was normal and there's maybe a slight uptick. Or there was a slight uptick in the last CBC and now we've recognized that it's even migrated a little bit higher. So our nurses have, because of this new tool, have taken a much more active and assertive role in the coordination of care based on their chairside clinical assessments. They've even contacted the nursing homes at times to say, hey, when's the doctor going to round in the nursing home? Please put this patient on the list to be seen because I'm concerned about sepsis. We had one case where the nurses had done that, and then the next day and the next treatment, on the next day, the next treatment, they approached me to say, hey, we're seeing a worsening condition as compared to when we called the last time. Can you call? I called, I asked to speak with the director of nursing, mentioned that not only has this patient continued to slip clinically, but we've also noticed that during the dialysis treatment, blood pressure goes a little lower than what we're used to seeing, and now this patient that used to transfer from the wheelchair to the dialysis chair independently is now requiring 2 people to help. That particular patient last year was definitely taken to the hospital for evaluation and had a reason to be admitted but never developed a bloodstream infection. So it's some of those case scenarios that over the last year we've really been able to build our confidence and our empowerment to really be the coordinators of care. Next slide. So
and Rochelle, this is where we pause. We have another polling question for the participants. Okay. The question is, does the dialysis facility where you work have a process of when to refer a patient to a PCP or emergency services? So their participants are beginning to answer that question. We'll just give them just a few more, maybe 10 seconds here. We're getting over 1,000 participants responding to this, and I will close that out. 3, 2, 1. Okay, so we had, again, over 1,000 participants answer the question, does the dialysis facility where you work have a process of when to refer a patient to a PCP or emergency services? And 794, or about 75%, said yes, they do, and 270, or 25%, said they do not have a process to refer the patient. So, Rochelle, with that, I will turn that back over to you.
Okay, so when we looked at our data, because now we have trends from 2016, 2017, and 2018, when you're accurate and meticulous about tracking and reporting the data in NHSN like we're expected to do, we were seeing a nice trend in our CRR rate. We went from 2.008, which was double what we should have seen in 2016, down to 1.533 in 2017. But remember, we didn't implement this project until halfway through 2017. So a nice reduction at 1.2 in 2018. Next slide. One of the unexpected surprises that we saw in this launching this ODUS tool was the primary goal was always to only really reduce bloodstream infection rates. We really weren't focused on outcomes related to sepsis. We knew we needed to use the sepsis assessment and education tools for early identification in hopes that we would catch infections before they progressed to a positive blood culture. We kind of made some assumptions that there would be a reduction in not only bloodstream infections, simple sepsis, severe sepsis, and septic shock because we focused on early identification. But the data actually demonstrates an overall reduction not only in bloodstream infections, but also in the number of patients hospitalized overall and the overall sepsis cases. So it's always about improving care for us in particular, but the outcome suggested cost savings through really seeing less hospitalizations and severity of illness. Next slide. So the sepsis coordinator at our hospital, Karen, tracked separately any of the patients coming into our hospital with an end-stage renal disease diagnosis on dialysis. So she separated that Excel spreadsheet to our hospitalized outpatient dialysis patients and the patients that were referred from outlying areas. She was pretty blown away by this slide. We actually met because we wanted to compare my outpatient dialysis records with the spreadsheet that she was keeping at the hospital to ensure the accuracy of the data and that it matched. So you can see that in 2016, we had, these are just patients from outpatient dialysis, our facility, that were hospitalized for any type of infection, not sepsis or any, we just overall infections. We went from 39 patients to 2017, 32 patients. Again, we didn't launch till the year was almost over, and then only 9 last year. So we really went back, could this actually be right? And both of us we're validating the data, so it really is what it is, and a nice testament to early intervention. Next slide. When we looked at our cases and pulled out just simple sepsis, we had 11 cases in 2016, 11 in 2017, and 3 in 2018. What was interesting when we did a deeper dive into those 3 cases in 2018, one had urosepsis but no bloodstream infection. And the other 2 cases of sepsis in that year, it was a single patient that actually had a bloodstream infection in July but was hospitalized in early August with a fever of unknown origin, and again in August with just some general weakness, complaints, but never went on to actually have a repeat positive culture. Next slide. So in looking at the number of severe sepsis cases and the trends, we had 6 in 2016, 2 in 2017, and 2 in 2018. Of those 2 in 2018, we had a much younger patient that had a cancer diagnosis undergoing chemotherapy, had a catheter as a sole access, The surgeon wanted her to complete her cancer surgery and complete chemo course before considering performing an arteriovenous fistula procedure. She had a positive blood culture and actually had a BSI twice in 2018, so a single patient with 2 episodes. She actually had severe sepsis in this particular case as well. The second severe sepsis case in 2018 was a newer patient to us, had a diabetic foot wound, catheter as a sole access, but did not have a bloodstream infection and had negative cultures. Next slide. We looked at the number of septic shock cases. Thankfully, there are not as many, 3 in 2016, but we had an uptick of 5 in 2017 and only 2 in 2018. Of those 2 cases in 2018, we had one with hepatorenal failure with a MELD score of 36, which suggests a 53% mortality rate within 3 months. This is someone that had no source identified, did not have a bloodstream infection. The cultures were negative, but had a very severe illness. The second case was acute septic shock. This was someone with an arteriovenous graft. No origin could be identified, so you can assume it might have been the graft, but there was positive blood cultures on that particular case. Next slide.
Okay, Rochelle, we're going to take a pause for a moment again for another polling question. It'll be the last polling question to the participants. How many patients at the dialysis facility where you work have had an observation stay or been admitted to the hospital in the last 6 months for a bloodstream infection? So again, we're going to give the participants just a little bit of time to respond. Getting lots of answers coming in. And we will close the polling in 3, 2, 1. So again, almost 1,000 participants responded. How many patients at the facility where you work have been had an observation stay or have been admitted to the hospital in the past 6 months for a BSI? Out of the 963, we had almost 57% say just 0 to 1 time, 31.5% 2 to 3 admissions, 8% said 3 to 4, and only 3.7% said 5 or more admissions. So, all right, Rochelle, back to you.
Okay. This next slide it's not the most up-to-date version, but it looks really similar. This is a refrigerator magnet that Karen had created and had our marketing department format with our logo on it. It separates the symptoms into zones. So green zone being a low risk for sepsis warning signs and recommended action really to do nothing because they're low risk. You have the yellow zone, which is a moderate risk for infection and sepsis, and the recommended action on our new magnet is definitely seek medical attention. And in the red zone, which would be high risk for infection and sepsis, the recommended action to call 911. Next slide. So some of the benefits that we've experienced from using the ODUS tool is, again, the CRRN rate came down. It really was the only thing different that we by implementing the tool from 2016 to 2018. We reduced the number of patients hospitalized with infections overall. It went from 39 down to 9 in 2018. We reduced the number of patients hospitalized with not only simple sepsis, severe sepsis, and septic shock. So when I added all those categories and you look at just sepsis in general, 2016 we had 20 cases. In 2017 it went down to 18 cases, and in 2018 we had 7 cases of sepsis. I do have to believe that that's a fairly significant cost of care reduction. People tend to do better when they're managed in their home and they stay out of the hospital altogether. When I first became a program director about 6 years ago, we weren't a 5-star facility. This designation is really something to be really proud of, and it's hard to keep all of those quality measures in check, and we were able to do that, so it's a great accomplishment. Next slide. So I do just want to, some of my closing comments, just to remind the audience that most nurses are innovative by nature. When you really gather your nursing team together and analyze data, brainstorming how to fix gaps in care, it's just been my experience as a nurse in a leadership position that direct care nurses usually have the answers. And when they're empowered, they really can help transform outcomes and come up with really great ideas on how to move the mark. We had an intuition that this project would improve our outcomes, so I submitted an abstract describing the project for the 2018 ANA National Symposium in Las Vegas. It was an honor to be selected to do the poster presentation. This was our poster. We didn't have a big, robust data comparison at the time of the conference last year, but I was able to take one of our nurses that was the most involved in this project, and it was just great to be there and share best practices. I think I've covered all of the objectives for my session, so I just want to thank everybody for listening, and are there any questions?
Thank you, Rochelle. That was a very, very good and informative presentation. There looks like there's a lot of questions coming in the chat, and that I will go over with here in just a second. I do see one thing that's coming in about copies of their tools that you've gone over, Rochelle. Are those going to be available? Do you have the permission to share those? I'm not sure which ones they're talking about. I'm guessing they're possibly the ones, there might be a couple because you did share a couple, the outpatient dialysis early warning screen or the low risk, high risk tool that you talked about too, that you made a refrigerator magnet. Would those be available to share?
I believe so. I definitely know that when we created this ODO's tool, this was just what we changed the clinical parameters. We just kind of guessed at how to put this together. And we did have this posted at one time, and I think it's still there on Midwest Kidney Network 11's website. So if you go to their website and you search for sepsis assessment, it should pop up.
Perfect. Okay. And do you know about the one that has the low, moderate, and high risk symptoms? Is that something?
I would suggest that because I don't have permission from our hospital yet to be able to post that or share that anywhere, you could certainly create that on your own.
Okay.
It is pretty similar. Our new one, if I can have permission to share it like we did on our Midwest Kidney Network with our other tool, I'll get with someone at the network and see if we can post that as well. It would be with our hospital logo, and it definitely has a little more detail with the recommended actions to take in the different green, yellow, and red zones. And it is a really good, we put it as a magnet because your patients, when they're that sick, aren't always able to articulate what they need to do. And so if there's a family member in the house that is looking at that magnet, they might be able to help intervene and seek the care that is necessary and urgent.
Okay, thank you. I just saw a question real quick come up to someone who's asking what is Midwest Kidney. So that is your local network. You may want to specify, do you know where the website is or what the website address is?
Oh, I can look it up. If you just do your search engine or Google search Midwest Kidney Network, it is our, it covers 5 states. Michigan is one of them, Michigan, Wisconsin, South Dakota, North Dakota, and I think Wisconsin.
That's network. Which
11.
Network is that? 11, correct. Okay. And I'm sure if you could just put in dialysis network 11. So thank you. Those were a couple things I saw real quick for just in general questions that come by. Again, as a reminder to all the participants, these slides will be made available within 10 business days. So this like Rochelle said, you can take a look at this and maybe even make up your own tool. So let's get to some of the questions because there is a lot, and let me just go ahead and get started. So the first question comes in from Susan. Does someone have a specific hand washing, access washing policy for the policy and procedure manual? Do you have, Rochelle, a specific hand washing, access washing?
That question's for me. Okay. We do. We actually have a hospital policy, and we use that within our dialysis unit. We also have purchased Sani wipes also that we put chairside. So if we are during our audits, we audit our caregivers, but we kind of have been watching our patients too. So when we see that someone has skipped going to the sink or skipped the hand sanitizer, we will actually hand them a single hand sanitizer wipe where we would expect them to wash their hands and their access.
Perfect. Again, Rochelle, these are for you. Kathy asks, related to Rochelle's comment that some patients with a BSI also develop sepsis. Question, aren't they one and the same?
They're not. I've actually, over the last year, really done my own personal education on sepsis and the signs and symptoms and the CMS core measures. So you can have someone, sepsis, you have to have an infection to have sepsis, but what we've noticed is some of our patients go in for sepsis, but their bloodstream infection, their cultures come out negative. So they're not really one and the same. I probably could have put some recommended articles and some of the education sources that I've looked at in collaboration with our hospital sepsis coordinator. But I think that there's, and me included, there's been an overall lack of really knowledge about what sepsis is and how to identify it.
That's perfect. Thank you. Yeah. Good question. There's another question. Well, I think there's a couple questions that came in. I think we've already addressed about the tools be available. So yes, those were going to be available as we talked about on Network 11's. There's a question from Tanya. So the nephrologist doesn't address the concern if the patient is in the red zone. I believe they're referring to your tool that you use. It says PCP. They refer to the PCP versus the nephrologist.
Yes, we always definitely keep the nephrologist in the loop, but if we've got someone in the red zone and we know that the patient is saying, and this actually happened last year, I have a wound on my foot, on my toe. So we never used to pull their shoes and socks off. Once they did that, this patient had a hammer toe and the skin was worn down all the way to the bone. So we always want to keep our nephrologists in the loop, but we also know that some of those, diabetes, those complicated conditions that the primary care provider is or should be managing is definitely consulted.
Okay. Robert asks, would you also do a blood culture before sending to a PCP if the score is above 3?
We are not. We have just our lab is right on site and they're the experts, so we don't really draw our own cultures. We don't want to get any false positives. They're used to doing it all the time. So if we have an order from the provider, primary care provider, I know on occasion they have given us some orders. We don't have our nephrology nurses pulling those cultures. We're pulling in lab or actually sending them across the hall to our drawing station.
Okay, thank you. Amber asks, would a 3 on the scale be considered in the yellow zone or the red zone?
Well, and I think that, as we kind of created this tool, we definitely have talked about some of the tweaks that we could put on here to help further guide. You would have to use your clinical judgment, and that's where the notes section, notes and actions taken, that's an area for the nurse that's maybe looking at a holistic picture and not really feeling they're scoring a 3, but they're not really anything different than their baseline, she might make a note, encourage them to seek care, and document that so that 2 days later when they come in for their next dialysis treatment, if then they slip into a different clinical presentation and a 3 or maybe a 4 that's showing up in the red zone, then they would be a lot more aggressive at they need to be seen now.
Right.
So you have to use your critical thinking skills and clinical judgment. You know, it's been my experience, dialysis nurses know these patients inside and out, and you often really recognize very, very subtle changes in condition even before you would even see a temperature variation.
Right. Okay, very good. Thank you. I have another question. Who do you call if it's a Friday afternoon or Saturday and the PCPs aren't available?
I think that would depend on, again, on your clinical assessment. If they're in the yellow, is there a walk-in clinic? You'd have to just really look at what do I know about this particular patient and how do they look today? How did their dialysis treatment run? Was it different? Did they have any complications during the treatment? That would then guide probably the response. If it's a Friday afternoon, yeah, you know, I'm thinking you're in the yellow zone. You should go right from here to the walk-in clinic. We've actually had this happen, and there's been some situations where we're calling the ambulance and they're being sent to the emergency department. And often what we've found and how our nurses have really gained a lot of confidence because we've seen they're usually spot on. And we've seen that, wow, you know, somebody was definitely had an issue going on, maybe sent home, or maybe admitted, but they're not showing up as positive cultures.
Right. Okay. Great. Couple more questions. We still have some. Lori says, are you also asking the nephrologist for blood cultures and empiric antibiotics or leaving the decisions to the PCP?
Sometimes the nephrologist will order the blood cultures, definitely. I have not seen them order antibiotics before the cultures are available, unless they're in the hospital and they have definite sepsis symptoms and they're part of the sepsis bundle. So there's a timeline of events that you have to do certain things, draw the lactate, get the cultures drawn, administer the antibiotic. That usually happens in the ED side. Because we're backed up in the outpatient side, we really are just trying to identify the signs and symptoms and have them seek appropriate treatment, because we have learned over and over, and you can see that in our 2016 rates, patients don't always really act when they know they don't feel well. And so if you let that linger too long or you go home, 2 days later they're super, super sick and really, really hospitalized, possibly in the ICU.
Well, thank you. Actually, I have just a comment from Peggy. She says, I was so impressed. Good job. It's so satisfying to get those results. So kudos to you and your team over there. I agree. This is very impressive information, and this is really proving that it can get done. So good job.
I do want to mention, thank you very much for that validation, but I do want to mention one thing. When we were at the ANA Symposium and people were coming to our poster presentation, there was a lot of interest. I think we had a lot of people coming through asking a lot of questions, but the second we mentioned, yes, this is done every day on every patient, there was a similar concern that, oh, we don't have time to do that. And so that was a real, what I would consider a real barrier to the implementation of even attempting to use this screening tool. But one of the things that we have learned in the last year, and I want to give this ounce of hope to people, yes, it does take extra time, and you have to find the time because you really can't afford to not do it. But when you do it consistently, 3 times a week, every time they come, we have found some of our patients, as soon as you get to their chair, they'll say, no, I don't have a cough. No, I don't have any wounds. I don't have any diarrhea. I'm not having a fever. I'm good. So they rattle off all of these things that we've been trying to teach them to recognize in themselves. And then we've also found one other interesting thing with our patient population is that depending on who the person is asking the question, I'm making a generalization, but probably you've experienced some of your dialysis patients will just really take a liking to certain people. And so they'll tell the person in front of them, no, 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 I'm good. And then they'll summon the dietitian over to say, oh, I have this issue on my foot. So we've seen them opening up in different ways to tell different people because they have a better connection with that particular clinician. So it's interesting that they've kind of memorized the questions. It gets quicker. When you launch it, it definitely is a change. It's a change in your workflow, but it's been a good one, and it does get quicker and easier as you practice it day in and day out.
Right, yeah. Thank you. I think you answered 2 questions coming up, but I'll just to verify, there's a question. How often and with which patients are you using this tool? Every patient, every treatment?
Every patient in every chair, every treatment.
Yeah, okay, just good. Thank
Sorry.
you. That's actually, we had 2 of them in there, so that's good. Here's a question. After first day of blood culture sent, some bacterial growth reported in the initial report. Patient received IV antibiotic after initial blood culture results. However, the blood culture had no growth after 5 days. Do we consider this patient with a positive BSI?
I'm not sure if I'm the right person to answer that. I'm not sure if anyone on the line is on the line from the CDC. I know we would report that. You have a positive culture.
Right, yeah. I agree. I think I would, but I would refer to the CDC question and help desk for that. Okay, so let's see. We've got we got time for just a few more. How do you handle a patient who refuses to wash their access prior to treatment?
Oh, we just continue to reinforce the education. We do our skin prep. You can't force them to do that, I guess. We have one person that will hold on to a paper towel and say, I'm not really touching anything because there's a barrier between my skin and the scale because I'm using a paper towel. And so you have to get creative with some of these people that refuse, but even if they're not washing their own access, we absolutely do our normal preparation of the site. So we know it's getting done. They're just not following the best practice. So continued reinforcement of education. I do love there's one CDC tool. It's a pretty small double-sided tool that's we went around chair to chair and gave it to all of our patients. One side is proper infection control practices for a graft or fistula, and the other side is for a catheter. So we just continue to pull out those resources and reinforce what they're supposed to be doing, and not forget to mention that you're not just making a decision for yourself. Your friend there that you talk to in the lobby is also dependent upon you safely washing your hands so that they don't get infection, because you may not get it, but you may spread it to somebody else.
Okay, good, thank you. Another question is just some of our patients do not have a PCP. What then?
Right, some of ours don't either, so it's depending on the severity of what you're assessing, go to the walk-in clinic or go straight to the emergency department.
Okay, I have a comment here, I believe. So from David, as a nephrologist, we would always want to know if patient had fever of signs or signs of sepsis and making decision as to where to refer the patient to ED, getting cultures, antibiotics, etc. I would not defer to a PCP. We do give antibiotics IV after culture is drawn when sepsis is considered. important for early intervention as mentioned. So just a comment there.
Great. Good comments.
Yeah, yes, we have a lot of good things. Let's see, so a couple other things, and then I think, yeah, we're getting close to the end, but I think we have enough time just for maybe one or two. Again, we're still getting questions about getting a copy of this tool, so yes, they're going to be available. The outpatient dialysis early warning sign screen is available. If you just Google Network 11 website, that should come up and you'll be able to find that tool. The tool regarding the refrigerator magnet, though, that would be something you would have to create at this time. It is not available for distribution. And we've answered the question about the assessment during each treatment. Another question here, has any facility used data in the EMR to auto-calculate this score on every patient?
Not that I'm aware of. We definitely wanted to start on paper, but it would be great because at the hospital our CRRS assessment is on the computer, so it will score it for you and give the recommendations right in the tool. And it will also show you when you're transitioning into a severe sepsis and come up with all the actions taken to meet the CMS bundle.
Okay. Well, thank you. And I actually think we have gotten through all of the questions and very good timing. So with that, I'm just going to kind of circle back here and close up the call. A lot of good information again, Rochelle, a lot of good promising practices and obviously proven practices in your case, how you've not only managed to reduce your BSIs, but actually still maintaining them. And very interesting that with the correlation between your hospitalization rates, it certainly makes sense when we look at our population of dialysis patients. So getting back to the participants, I really want to loop back and ask the question to all of you, what did this call mean for you? What now can you take away from this call that you can commit to implementing in your facility? You will be asked this in the post-survey at the end here. We're going to be asking you in May with our next BSI QIA LAN, what you've implemented. We really want you to take away something that you can do that will really impact your patients and your patients' outcome and helping to reduce the BSIs. And if your facility, you're listening to this presentation today and you have a promising practice or sustainable practice that's related to reducing bloodstream infections, we want to hear from you. We like to feature facilities that have a good story like Rochelle has told us. We want to hear about that, and we would like you to let us know if that's something you're interested in doing in future BSI LAN meetings. We would really like to feature you. Our next one will be May 7th. If you're interested, please get with us. Let us know. We'd love to hear from you. With that said, you can also follow us on social media for any updates. We're on YouTube, Twitter, and Facebook. And as I mentioned earlier, please stay online just for a quick post-survey if you're interested in CEUs. Once you finish that survey, you will be prompted to finish your CEUs and get your certificate. And I want to thank again everybody for participating. I want to thank everybody for attending today. Very interesting meeting, a lot of good information. Real quick, we've got 6 minutes. I want to loop back to, for some of you who maybe did not see the loop that was showing before we started the meeting, the pre-work questions that we sent out to all the facilities. I want to just share with you what the responses were. One question was, does your facility utilize any type of BSI risk assessment? We heard Rochelle sharing one today. Out of the 749 respondents, 507, or about 68%, said they are using some kind of BSI risk assessment, and 242 or 32% said no, they are not. So hopefully after this QIA today, a lot more will be saying yes, they're using some kind of assessment after the tools that Rochelle has shared with us. The second question, Do you know what your NHSN standardized infection rate for dialysis event bloodstream infections are in your facility? Again, we had 747 respondents. 629 said yes, they do. That's 84%. And 118, or almost 16%, said they do not know what their standardized infection rate is. So this is some information you just need to go back to your facility and ask your manager or someone in your facility about that. It's a good thing to get posted. I think Rochelle talked about posting days since last infection rate. That's good to get posted, but also your infection rate should be shared in your facility. So again, we're right on time. Thank you so much, everybody. Thank you, Rochelle, and we'll see you next time. Have a good day.
Thank you.
Thank you.